Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. Today, we're discussing the embodied experience of racism and how it impacts healthcare. Many countries have a history of racial discrimination and racist policies. Racism shows up in our homes, it shows up in our schools, it even shows up in our government. It also exists in our healthcare institutions and in our healthcare policies. We know that when individuals or groups are subjected to racism, that it can actually change their biology. Racism most definitely is a persistent stressor that causes psychosocial distress. And when I say distress, what I really mean are conditions such as anxiety, depression, panic disorders, and post-traumatic stress disorder. Neuroscience tells us that racism activates the hypothalamic pituitary adrenal axis in our brain. This chemical pathway then releases a wave of stress hormones such as cortisol and adrenaline that circulate throughout the entire body. And persistently high levels of stress hormones are associated with conditions such as chronic pain, anxiety, diabetes, and even affects learning and memory circuits in the brain. Racism even has an ability to impact one's genetic code and their DNA. A persistent stressor like racism changes one's DNA, making it a social determinant of chronic health conditions. And this altered DNA can be passed down from one generation to the next and to the next, maintaining poor health. In this way, the lived experience of racial discrimination can actually get under the skin or become what is known as embodied. My guest this week is Dr. Lisa VanHoose. Lisa describes herself as an intercultural guide that can help you make uncomfortable situations and topics such as racism comfortable and potentially even exciting. She's a clinical professor at Baylor University in the physical therapy department. Dr. VanHoose is also the founder and chief scientific officer of the Ujima Center. The center's mission is to improve Black health outcomes and patient satisfaction. Dr. VanHoose has investigated workforce diversification and racial health disparities since 1995. I'm always excited when I have an opportunity to hear Lisa speak because each and every time I learn something new. Her forward-thinking perspectives and the great work she's doing for all people impacts healthcare, it impacts pain care, and of course, impacts physical therapy. Okay, without further ado, let's begin and let's meet Dr. Lisa VanHoose and learn about the embodied experience of racism. Hi there, Lisa. Thanks for joining me today.
Thank you so much for having me. I'm excited about this conversation.
I am too. We had a whole conversation before this, which I'm sure lots of people would have liked to hear and had access to, but I'm excited to speak with you. You did write a chapter in our recent book called Integrative Lifestyle Medicine and Physical Therapy, Oncology, which is one of your specialties. So we want to thank you for that and point people toward that. But today we're really talking about white body supremacy. And I reached out to you about that topic and other topics that relate to diversity, equity, inclusion in physical therapy and healthcare in general, and how it relates to pain management. If it's okay with you, I want to read a definition of white body supremacy for people before we begin to help us inform this episode today. So white body supremacy can be defined as individual and institutional attitudes, practices, and policies that elevate the white body as a standard against which all persons' worth is measured. White body supremacy is a form of embodied trauma. It's a response that results from the intergenerational transmission of oppressed, race, bias, and fear that is held within the body. This construct is grounded in the belief that racism is sustained in the body, and that although cognitive processes are helpful, they are alone inadequate to address racism, that we must address it somatically in the body. And I reached out to you about that because obviously it's talking about addressing racism somatically in the body. And we as physical therapists play a strong role in treating the body.
I definitely agree with that. And I would say that we as physical therapists and physiotherapists, I think for us to be able to elevate our practice, we need to understand that concept and understand how that our interactions with humans that we are privileged to serve can be healing, they can be traumatizing, or even re-traumatizing. based on our knowledge and our understanding of how the body does always keep score. So I'm excited about this conversation.
When people hear white supremacy, they start thinking to themselves, well, what is that? And where is that kind of showing up?
Yeah.
And, we're talking about this as professionals, PT to PT, so to speak, healthcare professional to healthcare professional. Does this show up in some way in our professional education as physical therapists?
Well, most definitely. I think we would be foolish to think that it doesn't. I think often when people hear white supremacy, the knee jerk is to be defensive. Right? Because of the connotations around that. I think we all, including those of us who don't identify as white, we have to understand that we live, particularly if you are growing up in the United States, in a culture that has woven this throughout the fabrics of our society. So if you think about like the things that you see on TV, the messaging, the way in which if something happens and a person who is non-white is involved, at that point, we give race or ethnicity. So the denominator is always whiteness. So we are all being planted in a garden that is constantly telling you that the definer of everything is white. And so because of that, you can't be shocked about this concept of white supremacy. And if you study Project Implicit's research, even those of us that identify as Black, those of us that identify as Asian or Pacific Islander, we often have the same biases towards whiteness as white people have. And it's all because we're all getting the same messaging. So if you think it's not happening in the physiotherapy world, I'm going to need you to sit and just reflect on that. Just have some moments of introspection. So yeah.
And by it being kind of baked into our education, that would mean it is in some way brought over into our clinical practice.
Oh, most definitely. Most definitely. So I think, AAMC, so medicine has been talking about this for a while. And as physiotherapists, we have to remember that our roots are in medicine. And so the curriculums that we use, the curricular resources, all of those have white supremacy woven into them. And so how you learn is how you're going to practice. And I have a good friend, Carla Sabis, who published some research a while back that said that even if your PT program goes above and beyond, and maybe they've got this very, social reconstructionism, social justice lens to their curriculum, or maybe it's just evidence-based practice in a particular content area, that within 6 months, you will practice like the people that you're with. That is how powerful environment is. And so we have to be thinking about how we are training people in school and also how we're retraining older therapists like you and I, Joe.
So the concept of embodiment is popular in the world of trauma.
Yeah.
They talk about trauma being an embodied experience. But when we hear that racism is embodied, it's a little bit harder for maybe a professional who hasn't spent time in this to really understand what that means and how that could possibly happen. Because it starts to point to the fact that, or I should ask you, are we actually treating trauma, or are we treating racism more specifically, or an aspect of the fallout from racism in our patients?
Oh, I would say, oh, that's a great question, Joe. It's almost like racism-induced trauma, right? And I think most of us are comfortable saying now that pain and trauma has a subjective component to it, right? Which doesn't devalue it. It just reminds us of how individual and how unique everyone's perception of their experiences are. And to me, the conversation and the science around pain should help us be able to better understand racism, because that's what it is. It's a pain that is invoked on marginalized people by society, and society has validated that pain and actually structuralized it. Right. So it's fascinating to me as someone who identifies as Black as my race and my ethnicity being African American, that we are leaning into this conversation about pain, but it almost feels like we're leaning away from this conversation about racism. And I often wonder why.
So as we look at pain as a biopsychosocial phenomena,
Mhm.
it seems like, as a profession, we've kind of worked our way through the bio well and through the psycho pretty well at this point. And really what you're saying in some way is that racism is a social construct, right?
Yes.
It's something that's happening in our environment, and it's worked its way into every aspect of our social environment, so to speak. And then the outcome of that is it shows up in our body in various ways, but pain could be one way.
Yeah, I definitely think pain is one way. And so I think, like, some of the myths that were out there, originally about, particularly persons who identify as Black having thicker skin, or maybe differences in, the sensitivity of their nerve endings. I often wonder if the inaccuracy in that myth wasn't because of the methodology, but because we were naming the wrong thing, right? That maybe some of the difference in the presentation of pain and the severity of pain isn't biological per se, but it is just how that person is just integrating all of this hurt, right? Which also causes inflammation.
Right.
So I do think that maybe as the science improves, and after we are all, or most of us are willing to acknowledge that racism is a trauma that is shortening people's lives and also their quality of life, that then we can really put more science behind this.
It certainly makes me think about ways we can then engage with the community, because if we're going to treat people in a one-on-one environment for their chronic pain, so to speak, that's going to take a long time.
It is going to take a long time. It's going to take a long time for us to have grade A evidence. But I think that there are things that we can do right now to impact lives right now. So in preparing for discussion with you, I was reading an article from Nobel. I want to say it's Knobel. It's a 2021 article. And so in this article, they were referencing a formula that talked about phenotypes and how that the phenotype, right? So how you present is basically your genotype, which is your genes, plus environment, which we all knew that.
Mm-hmm.
But then they added in triggers. And then they also added in chance. And I was thinking about that. And I was thinking about how any of the isms, be it racism, sexism, right, homophobia, they increase your risk for triggers. They increase your risk for higher chances of trauma, and how all of that impacts your phenotype. And it actually decreases your odds of being well. And so I was just like, could we have this conversation around isms from that light? Would people be more open to that? Instead of, when we start talking about isms, they just poo-poo it as, that's just your feelings.
Mm-hmm.
But I'm like, but everything the body responds to is about feelings. Like, if it's too cold outside, that's a sensory response. There's a feeling component to that as well. But it's fascinating to me how some things are okay, some things align with someone's reasons, and other things they're like, no, that can't be possible. So then to me, then that's where people have to be willing to do their work and challenge their biases. Because as healthcare providers, if I'm not willing to recognize someone's perceptions, right, then I'm not willing to provide them individualized care.
It's not right. It's not person-centered care at that point.
No.
Right.
No.
And in not recognizing your own biases and not recognizing that person's experience, their life experience, their lived experience, then in some ways you're discounting a potential vulnerability that they may have been exposed to in their life, which is informing their current pain experience.
Yes. And that to me is the definition of supremacy, right? The fact that I have decided that my understanding of your condition and what you need is better than yours.
Say that one more time for me.
That I am deciding that my interpretation, my definitions of what you are experiencing is more important than yours, even though they are your experience. So if that is not supremacy and colonizing someone's lived experience, I don't know what is.
So that takes a lot of inquiry from the side of the healthcare professional. And I also think it takes a lot of self-inquiry.
Yeah.
before we started this episode, you asked me about me and my life, and we spent some time just chatting and learning about each other to kind of inform what we're going to do here today, basically. But I question, and maybe you have some information around this, either in school or in continuing education, are we helping professionals really work their way through their lived experience to see how it's impacted their health, and then to see how their thoughts and beliefs, because really we're talking about beliefs when we talk about bias, have an impact on the therapeutic exchange or the therapeutic alliance.
No, I totally agree. So I have had the pleasure of working with faculty at Regis University. And part of what they do is each learner does an intercultural assessment, right, with an actual reliable and validated tool. And I would say the majority of the learners who identify as white, when you ask them about their culture, when you ask them about their understanding of why they do the things they do, most say, I don't have a culture, right? And you have to like walk them through the dimensions of diversity wheel. You have to kind of say, tell me about your family, tell me about your favorite holiday, what's your holiday traditions, who do you hang out with? And so I do agree with you that for a large population of the American society, they have not done that work of really just sitting down and going, who am I? And so there's that part of it. But then I say that people in general, because we're so caught up in being busy, that we don't practice the pause, right? We don't value the silence of sitting with yourself and the power that comes from just sitting and going, who am I? Why am I doing what I'm doing? Where am I headed? What do I value? Because those are the things that define your mental models, and your mental models will ultimately define your behaviors. And I think as we were talking about initially, that PTs or physios, we don't understand that we might be the most important intervention. Yes, manual therapy is great, biophysical agents, right? All the things we have in our toolbox. But in my mind, you may potentially be the biggest predictor of someone's success in their PT clinic, in your PT clinic.
The human intervention, so to speak.
The human intervention. So I think you can have the best skills possible, but if you do not understand the power of the human intervention, your treatment may have a temporary benefit, but not a long-lasting benefit, or you might potentially be causing that patient harm. Mm-hmm. So I think like some of this health disparities data that we see, we're not yet at the place where we can tease out maybe some of that negativity in outcomes is because of the providers.
I mean, the psychology world has provided us with a lot of data in that area because they have whatever, CBT and ACT, and they have all these psychological interventions, but there's a whole lot of research that shows that the interventions are wonderful, but really what they're doing in some way is they're optimizing the therapeutic relationship. They're not necessarily, the intervention itself doesn't necessarily have a whole lot of power on its own in certain contexts, basically.
Yeah, no, I totally agree with you. And I think coming from, that psychology body of literature, they have shown us also that there's power in having concordance of some affinity with the people that you serve, or doing the work to have a shared value set so that you can make that connection, right? And how that health outcomes really are associated with connection. Mm-hmm. Right. So even when, like I know the hot topic right now in PT private practices, decreasing no-shows, but there are a few really well-published articles that say, make a connection. If you make a connection, that will substantially decrease your no-shows.
So if I'm kind of tracking with you here, in the pain world, especially in PT, we've spent a lot of time, and I'm actually a part of this, a lot of focus on psychologically informed pain care or psychologically informed physical therapy. Yeah. But the narrative you're kind of really building is we really need to have socially informed pain care or socially informed physical therapy.
I love that. Ooh, I might use that. I'm gonna borrow that and give you credit for it.
You don't have to give it. Did we coin a term together?
It's just coin a term because there has been pushback to, like culturally responsive care and culturally responsible care, which culture is social.
Mm-hmm.
It all comes down to social, right? So when you think about your families and friends, those are your interpersonal connections, which are social connections, and then how you navigate society. It's all social. So I love that socially informed care, which then might make people more open to having conversations about zip code related care, right? Because we know that that's also a really strong predictor of health outcomes.
Tell me a little bit about zip code related care, because you and I spoke earlier that I've worked in New York City in what I would consider extremely wealthy neighborhoods. And I've also worked in neighborhoods where there's poverty.
Yeah.
And I've noticed that the bodies that come in and the outcomes are different.
Very different, very different. And so your zip code is going to dictate both access and quality to most of the things that are key to life. So education, so the quality of education, the access to education is based on zip code. Health is all about which zip code you are in. Are you going to have access to good nutrition? Are you going to have access to physical activity resources? You're going to have access to providers. What's going to be your burden of care? All of that is related to zip code. I was looking at an article, which I about fell out of my seat, Joe, when I read it. And granted, this article is probably about 20 years old, but I'm curious to replicate it. I'm like, do I have the bandwidth? But it was talking about how that for 80% of Black patients, their care was provided by this small subset of physicians, right? And it was basically because, and I started thinking about this because I first read it and I was like, that can't be true. But we know that there's a small subset of providers that are willing to do care in Black communities, underserved communities, right? And so, like, even when I think about the practice that your practice as a physical therapist, there are very few therapists that are going to be willing to go and provide care for marginalized communities. And so this article was talking about, just the burden associated with that. When you have decided as a provider that you are going to go do this socially informed care, knowing full well that you are fighting mountains, right? It's not just about, we try to make it sound like, for pain or for any, impairment, body structure and function issue, that these are individual factors, right? If we just address what's going on with the individual. But no, I mean, you're fighting societal influences on health. And you as a provider, then knowing that you're going to be held responsible for that. And sometimes your pay is even going to be docked. Right, based on how some of these quality measures are put together.
Right.
Yeah, so it's really interesting how the system has been set up in such a way to discourage people from taking care of some of the people that deserve equitable care.
Right. And with that, it leads us into the idea of feelings of injustice that people experience with the healthcare system and with healthcare providers. How, pain care, so physical therapy in many ways sits in a kind of broader field of pain care, if you will.
Yeah.
How do we start to shift, or how do we bring social justice to, let's just talk about physical therapy first, because most people listening to this will be PTs, but how do we start to bring a social justice lens to physical therapy care in pain management?
I think we have to figure out ways to structuralize it. So I used to believe that we could just teach people to do the right thing. That was very Pollyannish of me. It has to be built into the structure. So I think that if programs, if clinics want to provide, if educational systems want to push socially informed care, then it has to be built into the performance evals, right? It has to be built into the patient satisfaction surveys. So there's a tool called the CARE tool, which asks the patient or the client or the individual, depending upon the terms you use, how compassionate was their therapist? How empathetic was their therapist? And then taking that tool and there being some teeth behind it, right? That this is something that we value and we're going to determine your livelihood based on, right? So it's shifting the power dynamics. Because ultimately, when we're talking about isms, power has to shift.
Yep. And right there makes people very uncomfortable.
Yes. Yes.
They're very uncomfortable with a lot of things that you just said, because it forces them to really look at themselves and say, okay, how do my beliefs about this particular person and who they are in their life experience impact the outcomes that I'm receiving? And now you're saying that my livelihood may be dependent on that.
Yeah.
Like I can kind of hear people saying,
Yeah.
well, whatever, you're Black or you're gay. Why is that my problem? Why is that my concern, so to speak?
Oh, that's a great question, because we're all connected.
Yeah.
Right. And so ultimately, if you have decided that it is okay for me to have increased risk of disease, that then is going to decrease my ability to maintain employment, sooner or later you will pay.
Mm-hmm.
So, and I think that's the part we forget, is that there is a connectivity, both known and unknown. And I talk about just reparations. Someone has to pay the debts that we allow society to develop. And you can either pay the debt now and deliver socially informed care, or you can pay the debt later with, we will have to cover this somehow, right? I want to say the last valuation I saw was that health disparities cost us about $80 trillion, right? And
Massive.
so when PTs want to talk about, reimbursement and why are we, getting this small amount and these regular cuts, I'm like, provide some equitable care, which would then be health savings.
Yeah, the care is substandard, basically.
Yeah, it's substandard and it's expensive.
Yeah.
So if we could just understand that social justice actually is going to benefit us, because if people were healthier, because we're actually addressing the root cause of their health issues, there'd be more money in the system. Then you might get paid more.
It's interesting because as a society, we look at education and healthcare as these kind of two topics. In your neighborhood where you live, when you pay taxes, whether you have children or not, that money goes toward improving the school. And we're all on board with that because well-educated children in our community typically lead to safer, more productive communities. But we have not reached the place yet where we see healthcare as a social justice movement, where when we invest in healthcare and your neighbor's health, it actually impacts your health and your well-being as well. So I appreciate you bringing that topic to light. I also want to make sure we mention your work at the Ujima Institute and tell us what your mission is there and some of the things that you have planned there.
Oh, wow. So I will say out loud that the Ujima Institute has been a blessing and has probably saved my life. Mm. And so we have now grown to the Ujima Center. So we have a physical location here in Monroe, Louisiana, which I did not plan on being in Monroe, Louisiana. It is the 7th poorest congressional district in the United States, but it has been a blessing for me to be able to be here. So at the center, we now have 5 entities. So the Ujima Institute, which was our initial body, still exists, but it primarily does continuing education, consulting work, training healthcare providers in the goal of decreasing implicit bias, the impacts of implicit bias. Because the literature is pretty strong that your bias doesn't change. It's your response to the bias that we're trying to get you to be aware of. Then we also have the Ujima Success Academy, which, thank you for the great segue, because the focus there is on education. So how do we improve academic and social development of children, predominantly Black children, so that they can enter the workforce and so that they can achieve whatever their definition of success is? And so we provide services from 6 weeks old all the way to 18 years old. So either it be childcare services, after school, or even mentoring programs. Then we also have the Ujima Wellness and Rehab, where we address all dimensions of wellness, either with our internal services or we partner with local communities. So if you are someone in Monroe, West Monroe, surrounding cities, you can actually show up at the center. We have an intake form where we ask you, what is it that you need? And then we walk that journey with you. And then we follow up. what I'm excited about is that we just received a grant. So we are going to be employing 15 teenagers and training them to be community health workers. And so each teenager will monitor, do surveillance on 5 families, reaching out to them monthly, finding out what it is they need, and then navigating them to services. And so then the other entity that is at the center is our foundation, which that is what does our fundraising and our friend raising to support the efforts here at the center. And then we also have our collective, which the collective is our policy making arm. Because as I told you before, I was a little Pollyannish at first, but policies are needed so that when people pass on or when the interest is no longer there, right? Because right now everybody's kind of hype on social justice. But, 4 or 5 years from now, when this is no longer a sexy, woke topic, we're going to need some policies in place to make sure that we are accountable to the things that we said we valued. And so that is what the focus of the collective is. And so our mission here is to advance Black health and wellness through our programming and with socially conscious partners. And we do that from birth all the way to end of life. So we've got some amazing partners. Greater Realness Cathedral is our faith-based partner. So it's been a fun journey. It's been a great journey.
So people will, of course, want to reach out to you and read all the resources that you have that you just mentioned. And this is why I wanted to have you on, because you're really leading this area for not only PTs, but many health professionals in this area. Can you let people know how they can learn more about you, your website links, and other ways?
Yeah, so you can go to the Ujima Center, so THEUJIMA center.org. I'm also on Twitter, so Lisa VanHoose PT or the Ujima Center. You can find us on Instagram, TikTok under that same, the Ujima Center. So yeah, we're learning the power of branding as well. We're watching you, Joe. We're watching the power of branding. But yeah, but if anyone, we're always open to these conversations about implicit bias, trauma-informed care. I love this socially informed care, even, racism, related traumas. Because as you so beautifully stated, psychology research has been looking at this for decades. Even in my own search, like finding out that in the 1950s, the government had started looking at the influences on racism and health because they were interested in the health of soldiers. Mm-hmm. But that literature never got to the public space. So we're actually behind on many of the things that the government has known for a long time.
I appreciate your work. And as you mentioned, we're really growing together, I think, in this area, because a lot of the work that you're doing is really impactful on pain management. And we have to bring a social justice lens into pain management, because treating it in the clinic is important, but people are coming to us with a whole life experience. Sometimes it's generations of experience that are impacting people just talk about the nervous system. And I'm like, no, it's every system of the body. It's not just the nervous system. You are more than a nervous system. You're a whole, complete human. And a lot of what's happened in your past is informing how you presently feel today. I want to thank Dr. Lisa VanHoose for joining us today on the Healing Pain Podcast. You can, of course, reach out to her directly at the Ujima Center. That's the ujimascenter.com. Of course, all those links will be available on the website at the Integrative Pain Science Institute. And make sure to check out Lisa on her social media as well. I'm Dr. Joe.
Joe, you just made me think of something, and I'm so sorry to interrupt you. And for those of you who know me, you know that I have like these moments where I'm like, there's a study. So I want to say it's 2019. So University of Delaware, New York University researchers looked at pain perception and what they identified. And so it was a sample of about, I think, 90 people. But we are more likely to perceive the early signs of pain in white faces than we are in non-white faces. And so as I was listening to you talk about like the intergenerational experiences of pain, it is our role as a provider to be perceptive and pick up on that. But the literature states that we have a strong bias, that we are only willing to accurately perceive it early in certain groups, right? And so the challenge to us is how could we be better, just better tools in the healthcare ecosystem. And so as I was listening to you talk about that, that it made me think of that study. So I'm going to stop perseverating, but I want people to know that there's just so much rich data out there, and we're not just talking about feelings. There is science behind this. If we would be willing to really be the evidence-based, evidence-informed practitioners that we say we are. So I'm sorry, Joe, but thank you.
That's okay. Thank you for your work, Lisa. And as you bring that up, the idea of perception, it really makes me think about our ability to perspective take on someone else's experience, right? And that's really what you're saying is, can you as a professional take a different perspective of a different human being and see how pain, physical pain or emotional pain is showing up for them?
Yes.
And some of it is implicit and some of it is a skill that we hopefully can teach people, right?
Yes, yes. If they are willing to be aware. And just as much time as we spend on our hands, we've got to spend that much time on our eyes and our brains and our ears, and even on our mouths, on the things that we say to people that may trigger pain for them. So thank you so much for letting me share time and space with you this morning. I hope we can do it again. I learned just as much from you in our conversations this morning. So thank you so much.
Thank you. We will do it again. We were on the dawn of Thanksgiving. So I just want to say happy Thanksgiving to all of you and to Lisa as well. And again, make sure to check out Dr. Lisa VanHoose's work. You can find her awesome chapter that she co-wrote in the textbook, Integrative and Lifestyle Medicine and Physical Therapy. That's on oncology, which is her other specialty. But of course, make sure with regard to this conversation to check her out at the ujimacenter.com. Make sure to share this episode with your friends and family on Facebook, LinkedIn, Twitter. You can tag me on Instagram. I'm always there. Happy to converse with you on this topic and the importance of it. And I'm Dr. Joe Tatta, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.